I'm Joel Kahn, medical doctor, triple board certified preventive cardiologist, and your host of HeartBrief. So we're going to look at a couple articles that came in the literature this week that are fascinating, and I hope you'll share the interest that I had in them. So let me go to the first one. This happens to be from more of a lay journal website called Our World in Data. And the title of this interesting report was What Americans Die From and the Causes of Death the U.S. Media Reports. I have been using this information that was published in 2016 in many of my lectures, but now it's been updated to 2023 with different media sources. Take a look all the way to the left. It shows you causes of death in the United States in reality from CDC data, where 56% of deaths in the United States were from either heart disease or cancer, and a small percentage for a number of other causes. But if you look at the three columns to the right, the New York Times, the Washington Post, and Fox News, if you look very carefully, you see that about 3% of the reports on causes of death in the United States are actually on heart disease, and about 4% are on cancer. So instead of perhaps 56% of the reports accurately representing the risk to the readership, you only get about 6 or 7% in the media. What do you get? You get overwhelmed with the reports on homicide, scare you, buy the next edition of the paper to find out more. Terrorism is a big portion, and drug overdose. So the point of this paper was to make an impact that many people get their medical information from the media, from the newspapers, whether they're what might be called more left liberal newspapers or might be called more conservative right newspapers. It simply doesn't seem to really matter. They're not getting truly a fair representation, and therefore they're not preparing for these causes of death with proactive preventive lifestyle, proactive preventive screening. Definitely a problem to work on, okay? I find that interesting. I hope you did too. Let me pull up a second article, and I believe it is, you'll give me a minute. Technology, as a former cath lab doctor, is important to me, but you still got to work on it. I believe it's this one that you're viewing right now. It's from PLOS Medicine, just published from an English group, NT-proBNP testing for heart failure diagnosis in patients with atrial fibrillation. And I hope you're familiar with the fact that there's a blood test that, frankly, I draw on every patient in my preventive cardiology practice. That was originally developed by a great researcher, originally from Detroit, Dr. Alan Mizell, MD, now in UCSD for a long time. The NT-proBNP test, or some people just call it the BNP test, was used in the emergency room in people that were short of breath to distinguish shortness of breath of cardiac cause versus non-cardiac cause. And it proved to be quite a good separator, and then you could work up following that pathway. Now it's extended into a routine outpatient blood test in many people, certainly those that are short of breath or a consideration of congestive heart failure. Again, I draw it in all patients. It's available from all labs. But one special group that is challenging is the atrial fibrillation group. And this study looked at a large website with among 155,000 people who in primary care setting had the NT-proBNP test, and about 17,000 of 155,000 had pre-existing atrial fibrillation. What they found was that in people without atrial fibrillation, the test was very good at subsequent diagnosis of heart failure. The low levels of NT-proBNP were much less likely to develop heart failure compared to those with elevated levels of NT-proBNP. But in the group with atrial fibrillation, all bets were off, because I've seen this thousands of times, is certainly if you're in atrial fibrillation when the test is drawn, the level will be high. It is a hormone released by the heart and in part by the atria. And if the atria are fibrillating, they will release a lot of NT-proBNP. So the point they made was you have to have a different criteria for normal and elevated NT-proBNP, or sometimes it's not even worth doing the test because it's so confusing if the patient's actually in atrial fibrillation at the time of diagnosis. So I do urge you to consider, certainly in your patients with shortness of breath, hypertension, left ventricular hypertrophy, cardiomegaly, left atrial enlargement, and other conditions, the NT-proBNP lab test. And it may be a predictor of congestive heart failure, but more difficult to use in those that are in atrial fibrillation. So not every test is perfect for every patient, right? All right, and the last one I want to go to comes from JAMA Network Open, and I believe I nailed it this time. Go technology. There is more squawk going on social media that your patients are watching about statins good, statins bad, statins dangerous. I get called a pharmaceutical shill all the time, even though I'm one of the more pro-lifestyle anti-drug doctors you'll find, but I do prescribe statins. So we need reassurance, and there's so many new papers about reassuring use of statins and lowered risk of dementia. But this interesting study, post-diagnosis statin use and breast cancer mortality, came from the Danish National Prescription Registry. 96,000 women diagnosed with breast cancer who subsequently, for some reason, were placed on a statin. And they could just track that within 3 years of the diagnosis of breast cancer, they either were on a statin or not. And of course, it would have been for a cardiovascular reason, not for a oncology reason. And they were able to look at the primary outcomes, including breast cancer mortality and all cancer mortality. And what they found in follow-up was that a number of people died from breast cancer, and a large number of people died from all other causes. The 10-year risk of dying of breast cancer was lower in people on statins than people not on statins, 11.8% versus 13.5%, an absolute reduction of 1.7%. And hey, if I had breast cancer, I'd want to grab on that advantage. And then they looked at all-cause mortality, and they similarly found a 1.2% absolute difference, 23.3 versus 24.5, but statistically significant. And they concluded that post-diagnosis statin initiation was associated with a modest reduction, but not elevation, in breast cancer and all-cause mortality. Perhaps a further investigation of prospective studies is needed, and that's certainly reasonable. By no means does this call for all breast cancer patients to be put on a statin, irrespective of their heart status. In my clinic, breast cancer patients do get a coronary artery calcium score and full lab panels, because for many women, their risk of dying is greater from heart disease than from their breast cancer. And if there is a need for a statin, I'm going to educate my patients now that there's a small chance that we may actually be reducing their breast cancer and their all-cause mortality by some degree. Great news. Never forget, eat that healthy diet, get that exercise, get that sleep, manage that stress, and don't smoke. So that's HeartBrief for this week's edition. Joel Kahn, medical doctor from Detroit and Boca Raton, Florida. Have a wonderful day.